I'm Sheila Bush. I'm the executive director for the Wyoming Medical Society. People will talk about the stool. So you have sort of these three tenets, if you will. You've got access to care, which most will either define as your geographical access or your economic ability, financial access. You have quality, and then you have cost. And in a rural state, the interplay between those three is just a little different than it might be in a more densely populated area. You almost, by definition, can't have all three. And that seems like a really hard thing to say, and a really unpopular thing to say, but it is the reality. We know that volume drives quality, and we know that volume drives down cost because of how you can just economically spread the cost over more. A surgeon who does 100 of the same procedure is going to be more confident and comfortable in that procedure, and statistically the outcomes will be better than a surgeon who's only able to do a handful over time. But neither of those speak all that well to the access question, because you can't then, if you're meeting those two things, you're not going to be able to put a surgeon in every Wyoming community. And those are really hard conversations. We're really, really fortunate in Wyoming that we have a citizen legislature. And for the most part, we have 90 individuals who live and participate in activities in their community and understand their community so well. In response to the opioid crisis, Wyoming felt like we had to also step up and do something. You want to address a problem. They convened a task force. They included a wide variety of opinions and backgrounds and expertise on the task force. Ultimately, we felt pretty good about where we got. There was some compromise. Senator Craig Thomas used to say, you know that you've really landed somewhere great when everyone leaves a little uncomfortable. And so he would always call it the sweet spot of discomfort. And I think that opioid bill did that, and they did it really well, and it was thoughtful. But one little piece that was a result of that ended up actually not playing out in practice the way everybody thought it might. I was able to have a conversation with the legislature to say, hey, we know what you wanted, and they're doing their best. This one isn't working. And we immediately got a response, and it was changed that next session. And so a law that went into place that maybe wasn't perfect, but we all did our best, needed a little tweaking. And 6 months later, the legislature not only addressed it, but made it effective, upon signature by the governor. We do some really cool stuff here. And because we can be flexible and because we listen. One challenge that we struggle with and have through time since my first being hired at the Medical Society is this question of who within the healthcare team should do what. And so historically, the state has played a vital role in delineating the lanes on that huge highway that is healthcare and saying, no, this is the physician lane, and here is that line, right? And here is the name the profession, and here's what you do so well and why you're so important. But here are the lines of your lanes. And just in the last few years, those conversations have gotten a lot more complicated. You're in territory where you've got to have a pretty deep understanding of the practice itself to even really be able to comfortably weigh in. And so legislators are saying more and more, like you're talking about specific procedures we can't spell or pronunciate, let alone weigh in and say, yes, you should do that and you should not, or you should all do that. And then you're asking us to have these in-depth conversations about what training might be required to safely do that procedure. And again, we're going back to we don't know how to pronounce it. They get emotional. People get deeply offended because people are passionate about what they're educated to do. And everybody wants to help patients. That's why they pursued the career, right? So at the end of the day, the ability to offend someone without intending to is really great, which makes it hard. COVID has brought great change to all of us in so many ways. We'll be counting the ways forever. But inside of healthcare, one really cool thing that happened was telehealth. Medicine can come up with all the ideas in the world, and none of them have a whole lot of impact until the public and the patient population says, oh yeah, that seems like a great idea and I'm willing to do it. Who can benefit most by having that cold or that ache or pain addressed via a video screen from the comfort and safety of their home it's that same population who's probably the least likely to want to turn on a computer camera and have a very, what they would perceive, intimate and personal conversation um, over the internet. That's been a huge benefit. I think the state's willingness to really talk about it, and insurance companies paying at parity, which means they're going to reimburse a physician the same amount of money whether you have physically darkened the doors of their office or if they've turned on a video screen and spent that time with you. um, I think has incentivized some reticent providers to say, I'm not against it, I can't afford it, I can't give up that hour with patients in my clinic to go see patients on my computer, because the hour costs me the same. It doesn't cost me less money. There's great savings potential to the patient. And so I think telehealth has been a huge win. And I'm excited to see how much of what was changed as a result of the pandemic sticks. You know, if there's one big challenge in front of us as a society, it's taking a really deep breath and identifying the risk associated with allowing politics to too greatly interfere and impact other aspects of our life that shouldn't. They really should be separate. Sorry about my dog. I'll see if I can get her to lay down. Lay down. Lay down. Pandemic hit us. Science is used to doing what they do based on mountains of data. They don't do anything without 18 peer-reviewed studies that all conclude the same thing. And right, I mean, it's years. And so when you talk about medicine and you look back at March, people wanted all of the answers right then. And science kind of went, whoa, but that's not how we operate, right? And so then we lived in a space of saying, we're going to do the very best that we can with what we know today, knowing it's maybe going to look different tomorrow, and that's okay too. But like, buckle up and hang in with us, which is really hard if you inherently disagree with one of those recommendations or anything along that path that you've buckled up for. It's pretty easy to unbuckle and be like, no. And also, here's all these examples of where you guys got it wrong. And I think my argument would be is they weren't wrong on that day. And the hard thing is there's always truth in all of it, right? It's that awkward family dinner when your sister hypothetically says all of it's fake and doctors are being paid to falsely report COVID numbers, and you want to like stab people with forks. But I would say, no, they're not being paid to falsely report, but then there always is that morsel of truth, right? Hospitals were given in like enhanced reimbursement because they understood how much of a tax it was for them to absorb those COVID patients and everything that went with it. And so, yeah, the federal government did say, however many COVID patients you have, like, we're going to do this enhanced reimbursement. Well, that can be extrapolated into they're being incentivized to lie. Well, right? So you're just not allowed to talk about things at family dinner. But I think that stuff's really tough. I think a big win for Wyoming is going to be having a pretty cool conversation about social determinants of health. Again, it's controversial, it's political, right? Like, people perceive it as like big government just doing a bunch of handouts. And that's not what it is. Being able to prove or provide a metric that says $1 spent in mental health is $10 saved in corrections. And those are totally made up numbers. I don't know. But they're really hard to quantify because there's too many variables. And so any sort of legislator or policymaker who doubts the genuine premise is also not going to buy in, because I can't provide this like graph that says X percentage of our incarcerated population has a mental health condition that, had it been addressed earlier, would not have manifested. You wouldn't be paying the hundreds of thousands of dollars in incarceration expenses if we had dumped more into that proactive mental health space.
My name is Diane G. I'm a physician here in Lander, Wyoming. I trained at the University of Wyoming Family Med program in Casper in the mid-90s and have gone from primary care to doing primarily emergency medicine in my career the last 5 years in Lander. I have been working in the acute care, and I was the public health officer at Fremont County at the beginning of the pandemic. Public health reaches into a different part of our community than, say, maybe some of the clinics might, because they might serve different populations. And prior to the pandemic, as we started to look around and see, what was going on in the world, we tried to come up with a plan to get out and start educating people about, at the time, non-pharmaceutical interventions, or NPIs. It was pretty much fire hydrants were wide open after we got that first phone call. Dr. Harris, who you all will meet later in this meeting, her and her team came to Lander, where the first case came from. And so that kind of started that first weekend. And then after that, it was really a scramble. Fremont County Emergency Management Team got together. We had met like the day or two before the first case, and after that, an emergency declaration was sort of made. And so we started working daily with that team to try to come up with ways to communicate with not only people in the community, but also providers, and try to set up some linkages there amongst everybody. And also trying to quantify how much disease might be in our community. If y'all remember, we didn't have much testing at that time. And then working with the hospital to try to help them out and thinking about contingency plans, because the first few patients were quite ill and our hospital was pretty inundated with critically ill patients. So it's been pretty fascinating for me to think about, like, watching the evolution of science in real time. We haven't really had that happen. I think from a testing standpoint, I think that would be the other big one. We had minimal testing available early on. And now we actually have fairly good testing. I think it can be better. I think the hope in the nation would be that we have a really rapid antigen test that's very inexpensive, that all of us could do, on a daily basis potentially, or as needed. If we could do that, that would help. And I think the vaccine rollout, that's going to be the big thing. I think Wyoming got some Pfizer vaccines recently. I think for some counties, the cold chain question was a real difficulty, and Dr. Harris might be able to speak more to that. But so I think Moderna vaccine, which is less reliant on that cold chain, is going to be one that many of us get in parts of the state. So I think that's the big thing. I think the other thing that's really fascinating as we learn more about COVID, we're seeing more long-term effects for people. Not very many people are dying, but there's long-term effects, heart, lung. I think that's going to be a big issue for primary care providers. And I think the population at large, as to what those effects mean long-term, as far as how they affect our day-to-day life and work and inability to do those things. To make. I know when I was in the county health officer role, obviously I had my personal opinions, which differ from other physicians on either side of me, actually, politically. Some were very much like, we need masks and shut down, and others were very much, let's keep things open. And I think politically, I think it would have been nice if we would have had more of a middle ground from the national on down. I think the governor tried a very he and Dr. Harris walked a really kind of good walk, I think, in the middle. And I think they took complaints from either side. But I think that middle road probably is the best when we look across the nation. I think a couple things that I think are here to stay. I think telehealth will be here to stay on some level. I will be interested to see if mask use becomes something that we do in the wintertime. I think all these non-pharmaceutical interventions are helpful, and we might see a decrease in the flu this year just because of what we're doing to try to prevent COVID in pretty good places, with, as far as like, the constant PPE use. I mean, essentially my day starts, I wear a mask walking into the clinic, and I'm wearing a mask and a face shield and a gown every time I talk to somebody right now, if they have COVID-like illness. Hopefully, as people get vaccinated, we can transition a little bit away from all of that protective gear. Although, we still don't know if the vaccines are going to prevent transmission. So that might reduce, I think we'll know more as more data, so again, we're waiting for data to kind of come up. So I think that will probably be most of our world, into the spring, at least, wearing extra protective gear. So that has been different. I mean, taking care of patients in cars is different, And so trying to figure that out, and I think as we transition more into in-house, in-person things, it'll start to look a little bit more familiar. I think in general, though, our probably healthcare providers' risk is bigger out in the communities. Just whatever we choose to do out in the communities, or what our friends choose to do. My personal opinion is it's going to be another 6 months to a year before we can start to really feel like we're back to a more normal life. And I think next winter, I'm going to probably personally wear a mask to work because I think it does help. And there might be that change in healthcare. I think a couple questions need to be answered. I think one, we'll have to see how many people get vaccinated. That would be one thing. And then as the data comes in over the course of the next 6 months from Moderna and Pfizer and other vaccine makers, how many people get the disease and can still transmit, even though I might not be at risk for severe illness from a Moderna vaccine or Pfizer vaccine, am I still transmitting? A couple of things we can worry about, obviously, would be the cuts in the public health budget and some of those effects, I think, and especially with the changes in the economy for the state, I think that's going to be a big deal going forward.
Hi, my name's Tim Thornell. I'm the president and CEO at Cheyenne Regional Health System. So structures of hospitals can vary greatly. We can be a governmental entity, we can be a not-for-profit entity, or we can be a for-profit, or as I prefer to call it, investor-owned entity. So real briefly, a government entity, as you would expect, is owned and operated by a form of government, whether it's the county or the state or the federal government. And then there's not-for-profit hospitals. So again, they enjoy, a tax benefit, usually being a 501c3 will be the typical tax status that they have. So we enjoy some tax benefits because what we do, there's a great benefit to the community for those services. So for example, every hospital has charitable care that they provide to community that we never get reimbursed for. And so as a not-for-profit hospital, which we are as well, we look and say, okay, we're going to provide, upwards of millions of dollars in charitable care to our community. For-profit or investor-owned hospitals, as they kind of suggest in their title, they have an owner, and their owner does have an intent to make some profit out of what's happening, and that's okay. There's nothing inherently wrong with that. And then we're also constructed in different ways in terms of being general acute care hospitals, specialty hospitals, or critical access hospitals. So general acute care hospitals are what we typically think of as our typical community hospital providing, a wider variety of services. Specialty hospitals, as their name implies, they specialize in something. So a good example of a specialty hospital is a psychiatric hospital. It may have a orthopedic hospital or a cardiac hospital as well. And then the third one is critical access hospitals. So this is a specific designation by the federal government that allows for smaller hospitals in more rural communities, and it provides a different funding mechanism to help them, really serve their communities in difficult places to stay open and function. Then limited to 25 beds or less. They do have a limited scope of services they provide, but it's so critical, the services that they do provide in their community. So certainly we're all, keenly aware of and facing COVID-19. Just in this, 10 short months, or may seem like long months, that we've been really had COVID thrust upon us back in mid-March. And you think back to the first part of the year, so I'll walk you through it kind of operationally. So in March, April, May, it was a period of time in which we were really preparing for the unknown, ramping things up, trying to figure out how do we combat something that we just don't know that much about. So our hospital, for example, we dedicated an entire floor, an entire unit, which for us is 24 beds, to help just to manage COVID positive patients. And we didn't know if we'd need that much or we'd need 3 times that much. But you have to pick a point and say, that's what we're going to, aim for until we learn otherwise. And in the process, through the federal government, they gave out an edict early on saying, don't do elective procedures. And the real rationale behind that was that we needed to preserve PPE, a term that we probably all come to know now as personal protective equipment. And so surgical procedures consume a lot of PPE, yet we know we need a lot of PPE to take care of COVID positive patients. But the consequence of that was that's where a lot of revenue hospitals generate comes from the surgical side of things. So all of a sudden our surgeries plummeted, how we made revenue. All of a sudden we had an influx of patients that were high need these are COVID patients, consumed a lot of resources. We didn't generate a lot of money. It put us in an inverted situation where not really anyone wants to be in terms of finance, a lot of expense and very little income. And it also just augmented in some of our requirements from staffing. We all of a sudden had to have staff that we've never had before screening everybody walking through our doors. We had to have more staff than ever cleaning. And then we saw people afraid, honestly, to go into hospital or to go anywhere. But it did deter some people from seeking care that they needed to seek. And then we went into this phase in probably late spring and the summertime where the COVID cases dropped. And even here at Cheyenne Regional Medical Center, we got to a point for a handful of days where we had 0 COVID positive patients in the hospital. And we got to do elective cases again. But we still had some fear from people coming into the hospital. We were still doing a lot of telemedicine or remote medicine to take care of people, which was a great learning lesson. And we'll still carry some of that through. And we got lulled, I think, into a little bit of sense of comfort in that, well, it's not as bad as we thought. And then we saw some events in the summertime and in the fall, certainly, where people started gathering again and the transmission really did occur. And then as the fall really hit, probably in September, October, really certainly by November, we saw it here locally in our county, throughout the state of Wyoming, and then nationally, the surge of COVID really increasing, and it impacted all of us significantly. So again, just by way of example, go back to that March, April, May timeframe, we never had more than 10 COVID positive patients in our hospital at one time. During this new surge in November and December, we hit a high of 63 COVID positive patients in the hospital. And with that, we had to defer some of our inpatient elective surgeries because we needed those beds to take care of COVID positive patients. We had to convert 2 entire units. Our entire 7th floor and our entire 3rd floor became dedicated to COVID patients. Our ICU has a capacity of 15, and we had at times our entire ICU capacity with COVID positive patients. We had to get a waiver from the state to open up 42 more beds, licensed beds, to be able to take care of patients and to be able to have additional space for ICU patients. As the prevalence of COVID spread throughout our community and our staff are living in our community, they too were subject to contracting COVID, and they did. Not necessarily in the hospital. We can't really trace any identifiable cases happening of transfer in the hospital, although it may have, but the ones we can trace all happen in the community. So while we reached that peak of community susceptibility, we also faced that with the hospital. We had over 100 employees out on quarantine. And of course, that coincided with the peak when we needed the most help in the hospital, because that's when the most patients were also hospitalized. Now, we had the foresight to see that coming down the road, and we had to react quickly. So we raised our hand for help, and we're very appreciative that we got help. We got help in a couple of different ways. One, internally, we did have to ask our staff, our nursing staff in particular, to work overtime to make up for those shifts. We also got help from the federal government, from Health and Human Services. They brought in what they call a DMAT team, and they're here for just 2-week increments only. We were fortunate to have them twice, so we had four weeks that they came in and had 14 people here, most of whom were clinical in nature and could really help fill in those gaps that we were seriously facing. And then we had the Wyoming National Guard come in. And so we have 10 Wyoming National Guardsmen here. They are non-clinical, but they provide a great resource to help supplement our nurses on our COVID units doing a lot of non-nursing functions. And then the final component is bringing in agency nurses from other parts of the country. And that's also difficult because every other hospital in the country is facing that same dilemma at the same time. There's not that many to go around. And so one, the price went up exorbitantly, 3 times what we normally pay. They're hard to find. So luckily, fortunately for us in Wyoming, the governor allocated $10 million in CARES funds specifically to help hospitals throughout the state secure this extra staff that we needed. So as we enter this next phase or next chapter in working through COVID-19, we now have a vaccine available to us. And here we set up the ability to vaccinate as many of our staff as we could right away. So within the first 3 days of getting the vaccine, we vaccinated over 300 people. And we also recognize, we have over 2,000 staff at our hospital, just again, by way of example, and we didn't get enough vaccine for everyone. And so it's going to be staggered out over the course of weeks and maybe even a couple of months to be able to vaccinate everyone that works at the hospital. But we obviously targeted those that are on the front lines, routinely taking care of COVID positive patients that are at greater exposure than most. So stepping away from COVID and just looking at healthcare in a broader perspective and looking at the future a little bit, what are our continued challenges in healthcare? And I would suggest really that the challenges we've been facing and will continue to face are access and cost. Realizing part of this balance is someone at the end of the day is going to pay for healthcare. So kind of on both ends of the spectrum, we have government paying for healthcare in lots of different forms. And so as we're going through some challenging times with the state government right now on finances, we got to find a way to still bolster our healthcare environment. Because if you don't, that cost burden will shift. And if you're in the private sector right now and have a business, large or small, you feel some of the burden too of healthcare costs. But if the state government pays less, does less, that burden and shift is going to go more to you than ever has before. So again, we have to watch really how we push and pull on the cost of healthcare, because it's almost certainly going to impact another group. You look at cost, and what we really realize is 25% of Medicare's spend, for example, is on the last year of life. 1/4 of everything Medicare spends is on the last 1 year of life. The other interesting statistic there is 50% of all the costs in healthcare are consumed by 5% of the population. About 50% of the population only consumes 3 to 5% of healthcare dollars. Then you have a segment that consumes a decent amount. Then you have this upper echelon, a segment that 5% of the population is consuming 50% of the total cost.
Hi, I'm Diane G. I am the president and CEO at Blue Cross Blue Shield of Wyoming. Healthcare in Wyoming is unique. The cost of healthcare in Wyoming is among the most expensive in the nation. And so that's an issue that impacts all of us. And so the question is often asked, why is that? And there are many thought processes behind that. And one of those thoughts is that the population in Wyoming is older and sicker than the rest of the country. We have data that compares Wyoming claims data to claims data from across the country from our sister Blue Cross Blue Shield plans that shows that Wyoming citizens are actually overall healthier than that of the rest of the company or the rest of the country. And so when we look at that, what we can see is that on a non-risk adjusted basis, that healthcare costs in Wyoming are 40% higher than the average of the rest of the nation, when it's actually risk adjusted, taking into account the fact that Wyoming citizens are healthier overall. Then the cost of care in Wyoming becomes 50% higher than the average of the rest of the nation. And so that's very significant. And so then we say, well, Wyoming is rural. But what CMS does is they are able to break the country down into what's called urban, rural, and super rural. And in Wyoming, well, we've got a couple of urban areas, and then the rest of Wyoming is considered super rural. But even then in the super rural areas, if you just look at that, we are 33% higher than the rest of the nation when it's compared Wyoming super rural to the rest of the nation super rural. So then you have to ask yourself, well, why is that? It isn't because we're older and sicker. It isn't because we're super rural. But I really think it comes down to this big question of cost versus access. In Wyoming, should every small town in Wyoming have a 3D mammography machine? Should every single rural hospital in Wyoming be performing hip and knee replacements? Again, I mean, I think that's a question that the citizens of Wyoming are going to have to address. And if they want that access, no matter where they live, then that cost is going to be there. And the cost of insurance is directly based upon the cost of care. And so if you look at, and AC, the Affordable Care Act premiums are the best method to utilize to compare, because they do all have to offer those essential health benefits. So it's a little bit easier to try to get apples to apples, even though it still isn't quite that. But Wyoming has consistently had the highest premium rates on the exchange since the exchange was implemented in 2014. Close to 90% of individuals who purchase coverage on the exchange do have access to those subsidies. Now, if you get over the threshold to where you no longer qualify for a subsidy, then it really is unaffordable. I could talk about COVID and the impacts that it's had on us for a long time, but I will try to hit just the highlights. What I would start by saying is that initially, when it really started hitting in March, one of our main goals was to not create any barriers to access to care. We leapfrogged our telemedicine policy, and previously we had only allowed telemedicine if an individual was in a provider's office in one zip code and was having a visit with a provider in another office in another zip code. Clearly, it made sense to allow telemedicine when the patient was at home, but then we had times to where the provider was also at home. The last half of March and April, our claims volumes did drop fairly significantly. The dollars didn't drop as much as the overall volume did. Then we started seeing a general uptick in May. June, I think, is what we would call a normal month. The first 10 or 12 days in July, we saw more prior authorizations than we ever had than we had in the entire July of the previous year. And so ultimately, July ended up being the highest month we'd ever seen in the history of the company for prior authorization. This is generally a very busy time of the year anyway. We're in December as we're talking here, and people are trying to get services done prior to the end of the year while their deductibles are met. But really, I mean, since that July timeframe, it's been very steady, and overall, our claims volume and our claims payments are very similar to what they would be in, if you will, a normal year.
So hello, this is Eric Barlow. I'm currently the Speaker-elect for the 66th Wyoming Legislature. I've served on the House Labor, Health, and Social Services Committee for the last 8 years. Number one thing that the legislature is involved in is ensuring public confidence or safety within the healthcare system. We're talking about practice acts. Who is a physician? Who is a nurse practitioner? Who's allowed to do chiropractic, hospital licensure, and all the different kind of healthcare providers. So then within that, once you build a structure and have the players, then you build in the different programs. So Medicaid, community mental health centers, all the different programmatic things. And then you start talking about how it actually plays out and what the needs are and what, the changes that are happening in the healthcare industry and how the legislature responds to those. Ambulatory surgical centers, something that we didn't have 10 years ago, 15 years ago. Interstate provision of healthcare through telehealth, as an example. All those things, they get at least their foundation of authority from legislative action. And certainly there are federal directives and federal components as well, particularly when there's strings attached to money. But the legislature helps lay that foundation that hopefully, and insurance is another part of that. We have an insurance code as well. So all of those different players, have a spot in that milieu of legislative authority. And then the legislature designates those responsibilities to agencies. So in 2020, the legislature has, well, first of all, we had a special session, the first one since 2003. And at that time, I think it was over healthcare things, believe it or not. And this year we had a special session to deal with the CARES Act, which federal government provided 1.25 billion. And the legislature came in and kind of outlined and gave the executive branch authority to spend those dollars. And some of those dollars were direct, or we anticipated would go toward healthcare, and we tried to help line out that type of program too. We've also been monitoring what some of the practice boards have done when it comes to telehealth. Labor Committee took up a variety of different issues this year. I would say probably the one that has the most across the board effect is a community mental health funding system. And we haven't made the change. This is a proposal that will come in a bill form to prioritize certain populations within the state. What we have had so far is a system that is an open access. Services available in all 23 counties. I think there's 18 different entities that provide them. Whatever your challenge was, whether it was a severe mental illness or family counseling, everybody was open to all comers. And honestly, because of our fiscal state, we've had to start saying, okay, what are the priorities that we're going to put state money towards? Now, as you know, the state of Wyoming did not expand Medicaid, so we're serving those less fortunate through this system. We're serving folks that have parolees or probationers as well. We're serving folks, that just have a need and come in. So the discussion has been, how do you prioritize populations? So we have a bill that kind of lays that out. And what we're trying to do is serve folks that certainly have a need, but also if we don't serve their need well, there's a additional future costs and additive costs to the state. A case in point is probationers or parolees with substance abuse or mental health, whether they're individually or co-occurring conditions, and they come out of incarceration, whether it's county jail or the Department of Corrections. We want them to have we want to prevent recidivism. And if we can help do that through substance use and mental health support, that's a priority to us. We just don't have as many general fund dollars to put toward that. So how do you adjust that? And we have it across many programs. How do you continue to maintain services, the same level of services, and spend less money? Well, you reimburse providers less. I think what we're looking at right now is about a 2.5%. That came up from the executive branch. Of course, the budgeting process is the governor, comes up with a budget based on the recommendations of his office, and then it comes to the legislature. The legislature works through that, and I think you're going to see that a lot of those programs are, kind of across the board 2.5% cut in reimbursements to providers. So what does that do? That, of course, puts a greater burden on the provider communities. And the providers, I'm not just talking about the doctor, the nurse practitioner, or the chiropractor, I'm talking about the hospital, the dentist, including long-term care. And long-term care, and we talk about different populations, talk about the elderly. 70% of the nursing beds in the state of Wyoming are paid for by Medicaid. Medicaid is a 50-50 program, approximately, federal dollars and state dollars. So so if you just do the simple math, 35% of the beds in the state of Wyoming in nursing homes are paid for by the state of Wyoming. Now these are folks that don't have the means and need the care. I'm not saying that this is an undeserving population by any means. I'm saying, but we're going to say, well, those facilities, we're going to pay them less to take care of these folks. These folks' needs didn't go down 2.5% or anything. Their needs are the same. So we run into a challenge, and it becomes even greater in some communities, because some communities may have a lot of private pay folks that can help soften the blow. Other facilities, they might be at 80% Medicaid patients or 85%. And so it challenges different facilities and healthcare providers differently. And right now we have our providers in the state of Wyoming, and I'm talking about all across the board, whether it's practitioners or facilities on the medical side, they're great. They serve our Medicaid patients and don't discriminate. But as our rates go down, they have a choice to make too, to maintain their business and et cetera. So the cost of healthcare, access to healthcare, and the policies that we implement, there's kind of an ugly mash at times. In 8 years, I think we make little stabs, we get little things, plucked out and say, hey, this can make a difference. And I think some of them do, but I don't know that we're getting to the bigger picture. And I don't know that yet. And hopefully we do. And maybe it's one little piece at a time, but hopefully we do.
I think that the first thing we have to be really willing to accept is that any change that's going to happen is going to happen really slowly and with really small steps. We can't expect, a 180-degree change quickly. It's just that's not the way it's going to go. I think for me, the best way to really talk about all of this and back to some of that conversation about access is to take that deep breath and take the step back and really approach everything with empathy and assuming the very best in people. I think we can get so far if we just start with, I have this major disagreement with whomever, but if I really do my level best of putting myself in their shoes and seeing it from their perspective, and while doing so, assume that they have the very best of intention, we'll get so much farther if we do that. And, take ourselves out of our individual sphere as much as possible, as often as possible, and always asking yourself, what don't I know? I feel so strongly about this or that based on what I know, but shouldn't I put an equal amount of energy into asking myself, what don't I know? What does someone else with a different opinion know that I don't? That if I found out, I might not change my opinion. I don't mean that, but I might have a really different perspective on how we negotiate or navigate to that sweet spot of discomfort.
The Leading in Wyoming podcast is brought to you by the Wyoming Community Foundation and the Dragisevich Foundation. Thank you for your support.